Good afternoon, everybody. Hi, and welcome to our the ARC of Massachusetts webinar series. Today, we're fortunate to have two leaders in the state who are really looking at supported decision making and how to help move this forward in Massachusetts for people with intellectual and developmental disabilities. So I want to introduce Michael Kendrick and Anna Krieger from the Center for Public Representation. And today we're going to be focusing really on supported decision making in the medical context. Welcome, and I have muted you all upon entry, and that's because we do record these sessions, and if the audio is good, it gets up on our YouTube page, so you'd be able to view the webinar again if you are interested. So anyways, we do use a chat box, which is on your tab, and if you are if you're familiar with supported decision making, can you please chat into me? Trying to get a handle on who's familiar with supported decision making? All right. So it appears that most of you are familiar with supported decision making, but in that range, it looks like Anna and Michael that some are a little bit, and some are very familiar. So, anyways, I think you have a little bit of range, but everybody at least has heard about supported decision making. And then I have another question for the audience, if you wouldn't mind answering. If you are a service provider, can you please chat into me? Okay, it looks like we have about 8 people who are service providers. How about if you are a family member or an individual that receives support? Okay, we have several family members, great. And if you are a medical professional or work in a healthcare setting, could you please let me know about that? Okay, we have a psychologist. We have some family members. Oh, we also have a nurse who works in a day hab and is also a parent, a physician. Welcome, Mark. An RN. Family support specialist. Great. Okay. So I see you're all able to use the chat box okay, which is wonderful. If you have any technical difficulties during this webinar, just let me know. I'm Carrie Mahoney, I'm the host, and so I am going to be, I'll be monitoring the webinar today. And at the end of the webinar, you will receive a copy of the presentation as well as a brief survey. So I just want to welcome you all again. And there you go, Anna and Michael. Please feel free to take it away.
Great, thank you so much, Carrie. I'm Anna Krieger from the Center for Public Representation,
And I'm Michael Kendrick from the Center for Public Representation.
And we're just so pleased to be able to talk with you all today about supported decision making. We're excited to get a chance to discuss it in the context of healthcare, because this is the area that we get questions about the most. From family members, from service providers, and from healthcare providers. So we hope to be able to answer some of those questions today in our presentation, and we'll also definitely be leaving time at the end to respond to questions that you might have, or specific examples, because that's always when the fun stuff gets started, when we get to talk about a real life example. So thank you so much. We've been working on supported decision making at the Center for Public Representation for a number of years, running some pilot projects that have now expanded all across the state of Massachusetts. And so that's where we've gotten our experience and understanding of supported decision making, is from working with people and really trying out these ideas in practice. So we are continually learning, and we're happy today to be able to share some of what we've learned so far. And Center for Public Representation, just as background, also is a nonprofit public interest law firm. So we also do class action cases on behalf of people with intellectual and developmental disabilities and people with mental health disabilities. So that's just kind of a little background about our organization. Carrie, could we have the next slide, please? Today, just our learning objectives, very simply, are we're going to provide an overview of supported decision-making concepts and how it works in practice. We recognize that some people have different levels of familiarity with supported decision-making, but we wanted to provide at least a basic understanding, because we know some of you are less familiar, so that we can then dig in further on the healthcare topics. We'll then talk about the challenges of using supported decision-making in healthcare settings and provide some strategies to improve those healthcare interactions. Next slide, please. So just to begin, we wanted to provide a definition of supported decision-making. It's an alternative to guardianship that allows an individual with a disability to work with a team of chosen supporters and make decisions about his or her own life. Supported decision-making really is centered on the idea of choice and self-direction. So it's a system that allows a person who has a disability to make decisions on their own behalf. And the way that they're able to do that is by picking one to however many, upwards of one, supporters who really know and understand that person, their needs, their will and preferences, so that they can assist them in getting to a point where they're able to make their own choices rather than have those choices be made for them. And just up front, we want to distinguish supported decision-making from shared decision-making, because we're talking about healthcare. Shared decision-making is something that is become very popular in the healthcare context, and it's different than supported decision-making. Shared decision-making is the idea, it's based on the concept of shared information between different parties, who are the person making the decision, the healthcare provider, and potentially other folks involved. It's the concept of shared decision-making is really about promoting engagement and understanding of information, so that people can make an informed choice about some healthcare decision. That is different than supported decision-making. Supported decision-making is going straight to the concept of capacity and competency. It's a system that supports someone so that they can be competent to make their own choices, versus and it's addressing directly their ability to make those decisions. That's different from shared decision-making, which is a way of conveying information and making sure that there is better informed consent. So we just want to make sure we have our terms clear up front. Next slide, please, Terry. So how supported decision-making works in practice, there's a couple of essential elements. The person with the disability is receiving necessary supports to make those decisions. And when we talk about it, this can involve large decisions or small decisions. And to dig right into healthcare, you know, there are big choices and little choices, right? There is the choice of what provider to even see, whether to see a provider, whether to get something as serious as surgery, or whether to just change a prescription to the generic brand versus the regular brand, the more expensive brand. So all those choices, it's interesting that we say big and small because we're really characterizing those choices. But to each individual person, those choices might have, what might seem like a small choice to one person is actually a big choice to someone else. And so that's where supported decision-making comes in. And the supporters are there to work with the person with a disability, make sure they understand the pros and cons of whatever decision they're making. And that's why it's so important that the supporters are people chosen by the individual with a disability. This is not something that is imposed upon the person. The central to the concept of supported decision-making is always that the person with the disability is the one choosing and selecting their supporters. They can hire and fire them at will. So that's the idea. It has to be someone who the person really trusts and really understands what their particular needs are. For example, around communication, someone with a disability might have very specific communication needs. They might not communicate in a way that other people typically understand at the outset. You know, one person we work with, she can understand concepts, but she really needs about 5 minutes of time after any question is asked to think about it and respond. And if you ask her to respond right away, she's going to give you yes, no matter what the question is. So her supporters understand that, and they can work with a healthcare provider or someone else to say, no, that's a great question, but we need 5 minutes, and let's reconvene in 5 minutes, and then we can give an answer. So that's just an example of the type of support supporters can provide to the person with a disability so that they're able to make their own choice. Supported decision-making also, it's consistent with the idea that people might be competent to make decisions in some areas of their lives, but not others. So it can provide that extra support in those areas where the person might not be competent to make decisions without that support. Next slide, please, Carrie. The role of the supporter, we've talked about this a little bit in terms of communications, but it's important that we recognize that the supporter's job is to honor and respect the individual's decision. Even if the supporter totally disagrees with the decision, they have to be comfortable with that dignity of risk, with allowing the person with the disability to make that choice. Their role as a supporter is just to explain and help the person understand the concepts that they need to in order to make their own choice. Next slide, please, Carrie. Today we're talking about healthcare. You can see our healthcare provider up in the corner of the screen, but there are a number of other areas that the SDM agreement can address, and we just wanted to flag those so people can understand that each supported decision-making arrangement is going to be memorialized in an agreement, which we'll get to in a moment. And that agreement can address a whole range of areas, and that's all determined by the person with the disability. That's just the concept of supported decision making is that you choose what areas of your life you want support in. And so someone might have an agreement that only addresses healthcare or addresses all of these areas that are mentioned on the screen. So what we found is almost everyone we work with, healthcare is one of the #1 things they want support with because it is so complicated and it's so central to everyone's life. Next slide, please. So at the Center for Public Representation, we do recommend that people memorialize their agreements in a written agreement. And just we wanted to share with you what a written agreement can look like, so you had that as background. And we encourage people to bring these agreements with them to their healthcare appointments because it's a formal memorialization of the system of supported decision making that an individual has set up. All of these agreements that we have done, every single one of them has been customized in some way for the person. So this is really like a template, and people take it from there. So they might have, they might customize it so that one supporter helps them with all their healthcare decisions and someone else helps with all of their financial decisions. Or the person might customize it in a way that there's a primary supporter who helps with everything, and then if that person's not available, there's successive supporters who help with additional. Who help if that first person isn't available. Next slide, please, Carrie. And this is just that example of how you might customize it and specify what areas you might want support with from a particular supporter. Next slide, please. We also want to flag for folks that we have people create these supported decision-making agreements. We do encourage people to get them notarized, and that's in part because we think that provides a level of formality that is important, particularly when interacting with a healthcare provider who might not be familiar with supported decision-making, because a lot of what Michael will be talking about is the education component of what families and people with disabilities and their supporters have to do in terms of educating providers who might not be on our webinar today and learning about supported decision-making. So we have that agreement. I guess we'll pretend that that star indicates that there's a notary there, notarization there. But we also want to mention that we recommend to people, if there is a need for a durable power of attorney, that they do execute that. We won't get into that today. But what is important for today's purposes is the healthcare proxy. The healthcare proxy is something that really every person should have, but it's an important component of for supported decision-making, but because it really goes hand in hand with your supported decision-making agreement. Most times, the people we've worked with have designated their supporter as a healthcare proxy. And it's just another legal tool that people can use in advance in order to designate what happens if they are determined to be incompetent because of an emergency situation. Then they know ahead of time who that person will be who will make decisions in a substituted capacity, in substitute for their own decision making, if there is that kind of situation where the healthcare proxy is triggered. But the healthcare proxy, again, only goes into effect in an emergency. So we found that for families who are potentially had been using a guardianship before and are now thinking of moving to supported decision making or trying it out, that the idea of a healthcare proxy provides a lot of comfort, because that is one of the big concerns. What happens in an emergency? What would we do if I'm no longer the guardian? And the healthcare proxy provides that added level of protection. The other form or document that's important, could we go back for 1 second? Thanks, is just down in the bottom there, the release of information. That's potentially a HIPAA release form. This can come into play if the person with a disability wants a supporter to attend a doctor's appointment, and the practice feels that it's important for the supporter to sign a release of information in order to be there and get the information. Now, we all know that a lot of times informally, supporters of people with and without disabilities are going to be attending doctor's appointments, and just an oral consent might be okay. But we think it's worth having a conversation ahead of time with a healthcare provider, which Michael will get into a little bit more, and considering whether something like this is necessary in order to make the healthcare provider more comfortable and more willing to provide the information that the supporter might need to communicate best with the person with a disability so they're able to make their own choice. Next slide, please. Here's just a little more background about healthcare proxies. And the one other thing to mention with the healthcare proxy is it's important when you're designating a healthcare proxy that when there's other supporters involved, that there's some sort of plan that you talk about ahead of time. So for example, say you have 3 supporters involved in supporting one person's life. One of them is the healthcare proxy. What happens if that healthcare proxy goes into effect? Everyone should discuss who's going to talk to whom. Is the healthcare proxy, they'll be in charge of making the choices, but do they plan on consulting the other supporters? Does the person with the disability want them talking to the other supporters about what's going on? Just coming up with a communication plan ahead of time can make a big difference for how that will work, ahead of time emergency planning. So I'm going to pass it off to Michael now. Next slide, please, Carrie.
Yeah, there could be many potential complications in terms of decision-making in the healthcare context. And so it is very hard to anticipate all of them and the kinds of support that people would need in those situations, because the healthcare subject matter itself is very, very complex. And this is very challenging, not just for people with disabilities, but generally for the general public. They find the kinds of decisions they have to make are often quite complicated. And another challenge is having to interact and make decisions on short notice, particularly with unfamiliar content. This is very challenging. It's not always challenging for people, but it's very commonly challenging to make up your mind in a hurry if you're being asked to do that, or to absorb what people are telling you and make sense of it on short notice. And medical settings are often quite busy in the sense of people don't have a lot of time. And so this is, it can be very challenging. And the amount of time, of course, in some instances, the medical personnel may have plenty of time, but you can't always count on that. So in this sense, it's just good to be very aware that the time is constrained, and for the individual and the supporters, then they would have to improvise and figure out, almost even in some cases, anticipate that they might have to defer decisions until another time when they've had time to think it over. Also, many medical personnel would have their own kind of questions about the competency and legal capacity of the person with a disability, and this may raise concerns for them. But these may never be sort of in the meetings that may go on, may not be necessarily even acknowledged as concerns, and yet may nonetheless have an impact on how that particular person engages. And in this sense, the assumption shouldn't be that everyone agrees that the person has legal capacity and competency, but rather that may be a fact that has to be established, either at that point in time or perhaps at another point in time. Next slide, please. Also, it's good to recognize that often people are interacting with medical personnel they've never met before, and the medical personnel have never met the people they're interacting with. So you've got an awful lot happening in a very short period of time where there is no relationship. People are unfamiliar with each other, and it's a very high-risk situation for misunderstandings and, if you like, not accurate conclusions about the other. And so it gets a lot easier when people have worked with each other before, when the medical professional has met the person and has interacted before, and where possible, you're going to get better results if you're essentially building a relationship rather than simply starting all over again with new people all the time. And it's not uncommon with people with disabilities to have quite distinct communication difficulties, and may have difficulty, in fact, understanding what others are saying in much of the subject matter. So the assumption that people are sort of, communicating effectively with each other can't be taken for granted as a kind of given. And so supporters, this is one of the things that supporters have to deal with, is to facilitate that communication. And that's why it's good to have supporters present at times, because they can kind of interpret what's going on and add a bit more clarity if that's what's needed. And it's also true that the person with a disability may need a lot of preparation before they even go to a medical appointment. In this sense, to get themselves clear about what their questions are and what their concerns are, and to then be able to, in a relatively short period of time, as I said, communicate those to other people. So preparation is the time of preparation is when you really aren't in the meeting or the encounter, because then you can rehearse a lot of things and clarify a lot of things that you can't do, and you have to do it on the spot. So much of the quality of a meeting may stem from just how well prepared people are going into it. So they don't, in a sense, have to think on their feet and in a stressful kind of context. Next slide, please. Now, it's also true that not all people with a disability are used to being their own decision makers. There are many people with disabilities that tend to defer to other people rather than assert themselves. And so there's quite a continuum of people's sort of readiness to step into the decision-making role. So in that way, the supporter really has to figure out where that person sits in that kind of continuum of asserting themselves, or whether they in fact will even assert themselves or simply say what they want people around them, to please the people around them or something of that sort. So in this sense, it's a very unique kind of question of a person's temperament and disposition, and really familiarity with being in the decision maker role. And so again, this is where what favors the person is, of course, having the right kind of support both before and after and during such encounters. Now, not everybody is very familiar with supported decision making. Possibly the people on this particular webinar are, but one can't assume that people in the medical context, whether it's people with disabilities themselves or families or medical personnel, are necessarily familiar with supported decision making, and it can throw them really to have to absorb that. So again, this is where some explanation being given well before a meeting to the people involved may simply set the stage for people being a lot more familiar with what goes into supported decision making, rather than have to again sort of act on the basis of information they don't really have. And one of the factors that I think would be fairly normal, not just in medical context, but in many contexts, is that it takes time for people to trust each other. And to assume trust in quick, encounters with what are essentially strangers is, it's not a particularly good assumption to make. The assumption should be that there might be challenges in building trust. And again, supporters may be much more familiar with the person and can support the person to be more trusting of these strangers, if that's the case, with medical people they've not met, and possibly vice versa as well, that the many things can make it possible for the medical personnel to kind of get who the person is and relate to them in a way that is going to be effective. It's also true that at the policy level in many medical organizations, there may be an absence of a decision one way or the other in regards to the role of supported decision making. So again, this may mean medical personnel themselves may need to check with their own organization about what the thinking is on supported decision making. And so again, this is by way of advanced preparation, that if they're advised in advance, they have the ability then to do some homework on supported decision making, check with their colleagues or the organization about what their view is of it, rather than be put on the spot with a practice they're unfamiliar with. Next slide, please. Now, it's important to recognize that not everybody is going to respect the voice and decisions of the person with a disability. We've had a long history of, in our communities, people ignoring people with disabilities and what they're saying. And so it would be a big assumption to assume that that's all gone away when we're in a medical context, because attitudes towards people with disabilities are cultural, and the culture of not taking the voice of people with disabilities seriously is often quite widespread, even though we've made this considerable progress. So it's important to recognize this is one of the matters that need to be thought through by supporters and how they're going to handle that sort of thing. And it's a challenge at the best of times to deal with unconscious and unhelpful attitudes, but they will be encountered from time to time. And again, the preparation for such moments is it's really hard to do it on the spot. What often happens in the course of people being involved in medical care is that the people aren't prepared for the encounter, and it goes off the rails simply because a lot of things that could have been done by way of preparation weren't done. And so that's why we emphasize that advanced preparation really makes the whole encounter more likely to be helpful. But at the same time, you can't always assume that the people in the healthcare context, whatever, are going to be prepared. And so you might have to, from the point of view of the supporter and the person with disability, anticipate that and have some kind of agreement about how you might want to manage it. Now, Anna had talked about the confusion between supported decision-making and shared decision-making. And just as a point to add to that, even amongst people that think they understand what shared decision-making is, there isn't agreement about shared decision-making. So no matter what term you're using, supported decision-making, shared decision-making, you just can't assume that everybody's using the same definition. If you do, that may leave you a bit surprised by how this one or that one might interpret shared decision or supported decision making. Next slide, please. I alluded to the whole issue of sort of negative historical assumptions in the general population about people with disabilities. And it won't just be about one thing. There are all kinds of different assumptions that people might make about people with disabilities. And some of those can be corrected on the spot, but sometimes they can't be. But they certainly do better when people have communicated back and forth about particular assumptions. And in this way, you can't always avoid challenges of that kind, but you can certainly facilitate supporters actually talking about some of the assumptions that you're detecting in your encounters with the people. The presence of good support is always a good thing, but it isn't always available to people. And so, in that sense, one of the limitations of a particular person with disability may kind of disappear if there's good support present, or in the sense of going from worrisome to much less worrisome. So, in other words, the key thing to understand is support can make a huge difference. And if you dump people into situations where they're not suitably supported given their needs, then things are going to be much more challenging. And many persons with disabilities present themselves in such ways that they often appear less competent than they actually are. And so, if you like, it encourages people to misunderstand them in a way. And so a lot of that can be offset by recognizing that many people treat this particular person as much less competent than they actually are. And you may simply want to have to say something about that at those times.
If I could just add, I think that's particularly true in a situation where the person has been on a guardianship, perhaps for a long time, and has a long-standing relationship with healthcare providers who've known that person in that context where someone else was making the decisions for them. And then when they start to use that supported decision-making model, it can be hard for people to shift that worldview and start to see the individual as more competent to make decisions when they're getting this specialized support.
Okay, next slide. Even though we've raised some of the challenges around supported decision-making, it is important to recognize that we are making considerable progress with supported decision-making. First of all, we have a national movement in favor of supported decision-making with all kinds of things happening. There's pilot projects, there's legislation, there's endorsement from mainstream organizations of all kinds, and that's happened relatively rapidly. So even though we've got quite a journey ahead of us, there's considerable support for supported decision-making, and one of the reasons there is because it is consistent with so many other advances in the role of people with disabilities, that in a sense the ground has been well paved ahead for the introduction of supported decision-making. So all of these various other best practices really have been consciousness raising and have shifted the thinking about people with disabilities. And so, concepts like self-determination, self-direction, person-centered practice, these are all examples of what are good practices more generally, but fit or dovetail very well with supported decision-making. It's also true that we now have families that, for instance, that have been involved with supported decision-making and have seen with their family considerable, meaningful progress. And so they may have started out with quite a bit of skepticism about supported decision-making, but now you'll see many families speaking up in conferences and things like that about the benefits of supported decision-making, which of course encourages other families to keep an open mind about it, and so it facilitates the progress of supported decision-making. And supported decision-making itself has been a catalyst for a greater life enrichment of the person with the disability. So it isn't just that it supports them in their decision-making, it can support them to get a better life, many of the things that are important to them. So in that way, it's not just about decision-making, it's about the decisions. And the decisions help create the kinds of life circumstances that the person is seeking or would benefit from. And the emphasis in current medical training on things like values and ethics has been very helpful because that provides a kind of a framework for how to relate to people and how to partner with people, including service users, and also things like holistic approaches to medical care, seeing people in their entire context, and also seeing the value of individualized approaches, shared decision-making, and so on, has been very consistent with supported decision-making in many, many instances. So these are things that are quite helpful as we go forward. Next slide, please. Now, just to step back a little bit in the area of strategy, the thorough preparation with all parties before appointments and meetings can't help but make for better meetings. And that's why we've emphasized it in this bit of an overview on this. The second is, if possible, continuity of key persons involved in medical appointments on an ongoing basis also is very helpful, because you don't start all over again with health issues around the individual. You really are building on the prior engagements with the same people. So if that can be done, that's also, it's not a panacea, but it certainly increases the probability of moving ahead. And thirdly, the question of thorough follow-up with the matters raised. So we're talking here about preparation, but we're also talking about follow-through. So in that sense, if there's a commitment to follow through on what comes out of these meetings, and that's done well, it sets the stage for whatever follows. And the education of people with the principles of supported decision-making isn't just a matter of introducing people to supported decision-making. It's working with the principles on a regular basis that's also very helpful, because principles always need application. It's not always self-evident what a particular principle might call for. And so you revisit typically a lot of these principles again and again. So particularly for people that are involved in any kind of practice over time, the principles become more and more grounded in terms of concrete conduct that you might undertake. Next slide, please. Again, the role of supporters now, some of the things that supporters do, just to make it more concrete. One of the things is, of course, if there is a meeting coming up or some kind of encounter with the system, it's very important to help the person figure out what the primary purpose of the meeting is supposed to be, and if there are sort of secondary purposes, so that they're really prepared for the thinking that goes into whatever those purposes might be. Now, it's not possible always to predict what meetings are going to be like, but to the extent that you can identify some central purposes and ready people to engage on those purposes, that will be very facilitative. In doing so, it also helps clarify what isn't clear to the person with the disability, and it provides an opportunity to figure out different ways to address what's not clear for the person. In other words, to support them in one or multiple ways, depending on what it is that they're having trouble at that point in understanding. And this isn't simply a matter of understanding what the issue is, it's also giving people time to process their own thinking, their own feeling about whatever it is that comes up, including their fears or their anxieties and whatnot. All of this is matters that you can do almost as preparation, as that then brings people into these meetings or encounters much more ready for them than they might be otherwise. And of course, it also provides for the supporter clarity about what in the world they should be doing to be helpful. And you don't have the same role each time you're with a person because the issues are going to be different. And what the supporter is called on to do might be different from one encounter to another. And so recognizing that means that the role of the supporter is not kind of, routine. You have to kind of think about each encounter on its own terms and be sort of ready as a supporter. Now, Anna did raise another issue, which is really the fact that people may have multiple supporters, and getting clear, if that's the case, who's going to be the supporter, who's going to be present, who's not going to be present, and why. And that individual, of course, ultimately has to make that decision. They also need to appreciate that they can switch from one supporter to another, or it could be done as a kind of team, a kind of collaboration. So all of that can be done, if you like, in advance of a known appointment or meeting or whatever. And it also provides an opportunity to, in some cases, to itemize the person's concerns and questions so they can be presented in a clear and quite brief way at the time of a meeting, because you've done all that work on identifying them beforehand and clarifying them and so on. Whereas if you had to do it in the meeting, that could be quite complicated. And also, there's the question of what are people expecting from meetings? What can be accomplished, what cannot? All of that's very, very important, because people's expectations, kind of set the stage for both understanding or misunderstanding what's going on. Mm-hmm. And next slide. Sorry.
I just had one thing to add too. I think this also, the role of the supporters in the meeting and in the preparation before, it's also a real opportunity for creativity, and that should be driven by what the needs are of the person with the disability. So the supporters might find communicating ahead of time in a visual way is the most effective way for that person to obtain information. So it might be a matter of providing pictures of something that's representative of some of the issues that are going to come up in the meeting, or searching for videos online of something related to the medical appointment, if that's the way the person processes information the best. And that's all highly individualized, and that's where the expertise of the supporter comes in. But we just wanted to emphasize that.
Yeah. So also we mentioned that the follow-up question, and one part of the follow-up is who's going to record what occurs in the meeting, and if you like to develop the list of follow-up items and unresolved questions. And again, that can be done after a meeting. It can be done to some extent before a meeting. Next slide, please. Now, one of the things that does come up is the educating people in the healthcare system about supported decision making, and the supporter is going to, and the people involved, you know, are going to have to kind of assess whether the provider has had any experience with supported decision making, if it's possible to ascertain that ahead of time, but even in the context of a meeting, and what might be the implications if they haven't. Might there be some way, for instance, to educate people by sending them something to read in advance, offer to answer questions at the beginning of the meeting so you get a measure of what they're clear on, what they weren't. There might be other written materials like the supported decision-making agreement or the proxy form, healthcare proxy form, and making, in some cases, the distinction between supported decision-making and guardianship or even limited guardianship, all of which may need to be explained. That one always can't assume that people are on the same page about that. And the release of information, as Anna talked about, that can also be something just to be mindful of. Next slide. Now, a stumbling block would be if the healthcare provider or personnel would not allow a supporter to participate in a medical appointment, then what may need to be done under those circumstances. And it begins with really understanding why this occurred, and then you're in a position to possibly remedy it. Not necessarily, but it's possible to remedy it to some extent. And it may involve talking not just to that person, but other people in the particular healthcare organization that might be able to, if you like, smooth things over or find a way forward. Now, this is a kind of informal advocacy kind of question, and trying to influence the organization. And you really often can only do that to some degree initially, because to shift an organization is much more complicated than to shift just the perspectives of one person. So in that sense, there would be organizations that aren't as hospitable to support decision-making as others, and that's to be understood as an expected thing, because you know, one organization isn't another.
Another stumbling block that is connected with this is what happens if the individual comes to a decision with the help of supporters, but the healthcare provider isn't willing to accept that decision, you know, believes that the person isn't competent to make that decision. I think the short answer to that is it's really a matter of education and helping the person understand how the decision, you know, it's really the job of the supporter to help communicate that decision. And part of that is helping the healthcare provider understand this is how we reached this point, you know, et cetera. So that's the other one we wanted to flag. And at this point, I think we're ready for questions. So I think the best would be if folks want to type in. Is that, Carrie, the best way to handle it? Or
yeah, so if anybody... Yeah, anybody has questions, just chat them in. If you want to pose your question to everybody, then everybody can read them, or feel free to chat it into me, and I will be happy to read it as well.
Great.
I think you brought up a really great point, though, about really preparation between the supported decision makers and the individuals, because that's just... I think so many times we just kind of, you know, good willing staff just kind of, you know, breeze into the doctor because you got to go, and there's not a lot of dialogue there. So, anyways, I thought that was a really good point.
And I think you also, someone's asking, is the PowerPoint going to be available for us to use with staff? I think the answer is yes, right, Carrie?
Yes. So after the presentation, we'll send you a PDF of the PowerPoint. And then also we will be, this has been recorded, so in a couple of weeks, we're going to be able to have it up on our YouTube channel, and we'll notify you of that as well.
And I should also make a plug. Could we have the next slide on, Carrie, just so people have our contact information? But related to that, we have a website, which of course I forgot to add onto this PowerPoint, but I'll work with Carrie to add that. but our website is in the process of being updated, and we'll have a lot of information right from this webinar available there. But our next question is, are persons with disabilities currently under guardianship moving through the courts to end guardianship in favor of supported decision-making? Great question. That is happening in actually a lot of different states, but I'm sure you're most interested in Massachusetts. And we do have one person who we worked with who was under guardianship, and we worked with his family. He tried out supported decision-making. It really worked for them. And so we petitioned the court to remove the guardianship in favor of supported decision-making, and that was successful. So the guardianship was removed, and he is now using supported decision-making for a number of years. So that is happening here, and in a few other states, those cases are coming up. And we do have legislation that we've proposed and has been introduced in the State House this session, which the ARC has been very supportive of, and we're grateful for. And that would require that, among other things, that when a guardianship petition is brought, that the court consider whether supported decision-making is a less restrictive option. So that would really mean that SDM is going to be considered in every future guardianship case. We should say this, it's sort of implicit in what we're talking about. Not everyone is going to be able to benefit from supported decision-making, but for those, we want it to be available for those who can. Our next question is, are you aware of any positive movements in medical school / nursing, other healthcare educational requirements? Michael, do you want to take this one? Or?
Yes, like the rest of us, medical people are learning about supported decision-making, and it is gradually showing up in the curriculum of various medical programs, but it hasn't been part of those programs for a long time yet. So it's not sort of, I mean, it's really in many ways just getting put into the programs. So we don't really have a long-term way of looking at what the impact's been. But generally, the very fact that we're seeing more and more supported decision-making concepts and so on in the professional training is a good sign that there's some receptivity to it, and it may, you know, in another decade, we might see a very different looking kind of arrangement around supported decision-making.
Mm-hmm. The next question was a follow-up about the court question. Along the same lines, if a clinical team is doing a clinical team review and would like to recommend supported decision-making rather than partial or full guardianship, I'll assume, how is that going in Massachusetts courts? And the answer is, you know, we actually get a couple calls every now and then from attorneys who want to recommend just that and are trying to educate their clinical teams that they're working with about what supported decision-making is. And we've done some education of some clinical teams directly about supported decision-making for some people who were considering filing a petition to remove the guardianship for. And we've done a lot of education of the courts as well, and they do seem receptive of the concept. So I think we're kind of on the cusp of the movement towards a real understanding of supported decision-making as an alternative in the courts. Another question is, if an individual has a guardian, how is there a gradual move towards supported decision-making, i.e. what is the liability of a guardian for a supported decision with which the guardian does not agree? That's a great and tricky question. I'll start, and if Michael has more to add. But the way we've done it is that, you know, people, ultimately, if you have a guardian, legally, your guardian could override your decision, even if you use a supported decision-making model, right? So for people who are under guardianship, but them and their families or whoever, their supporters, are interested in trying out supported decision-making, we've had them try out supported decision-making model. And we've always, in every one of those cases, the guardian has been one of the supporters, because that's just happened to be what the individual wanted. You know, so the individual with disability had a parent as a guardian in this example, chose to try out supported decision-making, and the guardian remained one of the supporters because it was the person's parent, and that was who that individual is going to want as a supporter in the future. But if there had been a situation that came up that because where the guardian felt the supported decision was not the right decision, the guardian could have overruled it in that situation, because really technically they're sort of trying out the model. They're not fully using the model because there's still a guardianship in place. So that's kind of the way we've conceptually looked at that and worked with folks around that. But everyone who's been sort of trying out supported decision making in our pilots has been doing that with the eventual goal of, if this works, we're going to try to remove the guardianship. It can get a little trickier if there's a plan to keep the guardianship in place, and that's kind of probably too much to get into for this conversation, but feel free to reach out to us if you have questions along those lines.
The other thing to think about is that all the big national organizations who have looked at this, including the National Guardianship Association, they've all said essentially the same thing, which is that we should start with supported decision making in the first place. And if it isn't able to work, then you could consider more restrictive options like limited guardianships or plenary guardianships and so on. Because what they're trying to say is, look, why restrict the individual and take away their rights if there's no need to do that? If the support can work for them, then you don't really have to go to guardianship. Whereas before, in many cases, people were told you go straight to guardianship if you have a disability. And that's now seen as much too radical, much too extreme advice, that the prudent thing would be to start with something like support decision making and just see how it goes, really. And rather than frightening people and think, well, guardianship is some kind of panacea in terms of protecting people, which it isn't. It only protects people to a degree, so it isn't a kind of a fail-safe and shouldn't be sold on that basis. But this is where people need to be familiar with supported decision-making and the pros and cons, as well as guardianship, and it's not always the case that people are.
Okay.
Are there any more questions?
Yeah, any other questions?
Well, if people do get questions later, once you get the slide, the copy of the slides, there's ways to reach us. So contact us at any point. We'd be happy to deal with whatever questions, even if they occur, later after you had a chance to think about things.
If you can't tell, we like talking about supported decision making, so we'll happily continue that conversation with you all.
All right, terrific. Well, thank you so much, Michael and Anna, and for this great webinar and just helping us, think this through. So I appreciate it, and thank you all today for attending. And just please fill out that brief 10-question Survey Monkey. Helps us so much to try to decide how to make the webinar series we do informative and giving you good information. So thanks, everyone. Hope you have a great day. Bye-bye.
Thank you. Goodbye, everyone.